the other piece, I wanted to reflect on here was coming back to this diagram, and what I've learned from Kiki Ojo is, when we look across here, everybody in this diagram, the three people, the tall man, the middle man, and the short man, they all want to see the game. But what is the game here? And I think, the game here we can think about as really being cultural capital, and access to the cultural capital that allows us to then live a fulfilled life. And that fence is the system that we've built that serves some of us, but not all of us. And, those of us who are tall can't actually even see the system for what it is sometimes, because those of us who are short maybe see it in a completely different way. And the answer isn't necessarily always just giving more resources or this idea of charity to people who are, in this case, short, but to really understand their perspective and work with them to tear down that fence and then build it back up in a way that allows everyone to have access to that cultural capital. And so I think that's sort of the analogy that I wanted to share with you today, because it was an insight for me. So that was an insight. I will say that it took, a long time to get to after working with this kind of diagram and thinking about these issues for a while. And I hope that we can explore it a little bit more today as well. But I want to leave you with some practical pieces as well, so that you feel like you can move forward in this space in your QI journey. And I'm going to sort of talk about, 6 ways in which I think that you can do that. So the first is, as I said, I do think it is really important that we prioritize the needs of populations experiencing poor health outcomes. And in primary care, I thought a lot about how we can do that. And, cancer screening was one of the early things that we tackled. But I realized, if we want to have the biggest impact on morbidity and mortality, and in particular, address issues that are more prevalent among people experiencing low income or who are marginalized, we need to start to do QI work in other spaces. And so we started to do work around opioid prescribing, which we know is an issue that more disproportionately affects people who are poor. And similarly, we then started a lot of work to try and cure Hep C, which again is clustered around people who have a history of substance use in the past, and again, many people who are living chaotic lives now. So these are areas that I'd say were a lot harder to tackle than cancer screening. And so it would have been hard to tackle early on in our QI journey, but I feel good that our work has shifted towards that. From a COVID perspective, I think it's, the vaccine rollout has really illustrated to us how this is important as well. We saw the science table come out with a brief, illustrating how important it was to have not just an age-based prioritization, but a neighborhood-based prioritization, and that's how we would save the most lives. Yet, we can see here early on, even after that report came out with the vaccine rollout, just going with equal allocation to different public health units. We see, the northwest area of Toronto, which I've highlighted before, is having that high COVID hospitalization and death rate. So you can see that the darker red in that northwest, having some of the lowest vaccination rates, which you can see here in the map on the right with the light colors. But at the same time, I think the good news story here has been that when we've prioritized, when we've flooded those neighborhoods with vaccine, given them more than the per capita share, we have seen a huge shift. And so we see from the end of March, those really low vaccination rates relative to other areas of the city in the northwest, and that growing then of the vaccination rates by May 10th, which was, I think, the most recent map that was released, thanks to these maps are from the local, and they have great animations you can take a look at to illustrate some of that progress. The second, strategy around addressing equity, I'd say, is to make sure you stratify the data. So if we only look at averages, so if we only looked at averages in that cancer screening example, we would have thought that this was all a good news story. We wouldn't have seen that there was a deeper issue here, and that actually the achievements were largely being borne by a certain group, and that other groups were being left behind. Of course, to stratify the data, you need to have data to stratify by. And so, if you're doing a patient experience survey, you can collect that data. But if you're using data from administrative sources or EMR, you might end up using age-based data, postal code as a proxy. But then in our practice, we did actually work to collect since 2013 socio-demographic data using some questions that were developed by Toronto Central and partners. And I've left the website there on this slide, so you can check that out. I will say, since this time, we've done a lot of work to actually unpack these questions, and we could, give a full talk on the questions themselves. And because those questions in 2013, we realized are a little problematic, and we have now new versions of them that we're testing out. But I'd say that, when we do stratify, it's important to look not just at the baseline differences, but also differential impact of your intervention. So what I'm showing here is some data from a paper we've put together around differences in patient experience by socio-demographic characteristics, and we've looked at it at 2 time points. So this is some older work again, but you can see in the middle graph here, we're looking at people who said it's very easy to get care after hours in their teams. And you can see that between 2014 and 2016 in the green dashed line, the average, it's improved, which is great news. But what you can see is that improvement is really borne out by the people in the red, which are people who report excellent health. And in fact, people who report poor fair health, which is the blue, have hardly noticed any improvement or hardly reported any improvement in after hours access. So it really spoke to us that, we're doing better, yes, but again, are we serving all of the people who we need to serve? And in fact, some of the people with the highest health needs are the ones that are reporting some of the barriers, so that we had more work to do. And if we hadn't stratified, we wouldn't have seen that differential impact of our intervention. So of course, stratification has been really important during COVID, the COVID vaccine kind of piece as well. And I think this is data from the ICES dashboard. I don't know how many of you guys have visited that, but I really like it. And what you can see here is the vaccination rates over time. The time is on the x-axis, and cumulative percent of Ontarians vaccinated on the y. And on the very bottom line, actually, unfortunately, is the neighborhoods with the highest incidence of COVID-19 infection. And you can see they had the lowest vaccine rates for so long. And we wouldn't have seen this unless it was stratified. And thankfully, due to some of those hotspot interventions and the targeting of vaccines to hotspots, we can see that line crossing over. And ideally, the blue and orange lines are actually far above the other lines, so not just equal with them, but above, because those are the areas that really need the vaccination the most. But, substratification is also important, because even though we're seeing a good news story in terms of the vaccine rates increasing in the highest risk neighborhood, which is the one column, we can see on the left here, we've got people who are recent OHIP registrants, so largely new immigrants, and long-term residents on the right. And you can see, if we look at the very top left corner, those 80 plus in the highest risk neighborhoods, 56% of recent OHIP registrants are vaccinated, compared to 79% of long-term residents. So substratification, to really better understand the issues, is really, so going deeper is important and can reveal new insights. So although we're doing better in some respects, there's still improvements, and this gives us some insight into that. When we are stratifying the data, I do want to mention that it is really important to involve communities in data ownership and interpretation. And I think, COVID again has given us a good example as to why. So, we've seen some collection of race-based data, or, looking at neighborhood data and racialized communities that way, and drawing some conclusions. And unfortunately, what happened during COVID is that, politicians and others often used some of that data to just perpetuate some negative racial stereotypes, and blaming certain communities for the bad outcomes they're seeing, as opposed to the structural factors that those communities are facing that lead to really poor health outcomes for them. So we don't want race-based data collection in particular to just perpetuate negative stereotypes. At the same time, I take the words of Abraham. I think about the words of Ibrahim Kendi quite a bit, who is a staunch believer that we do need to look at race-based data. And, even though racial categories are constructed, the racial inequity that we see in our society is real, and and only through collecting that data can we actually see it. If we stop using racial categories, he says, then we will not be able to identify racial inequity. If we can't identify racial inequity, then we'll not be able to identify racial policies. If we cannot identify racist policies, then we cannot challenge racist policies. And if we cannot challenge racist policies, then racist power's final solution will be achieved, a world of inequity none of us can see without long resist. So stratification allows us to see, but at the same time, we have to do it carefully and with community involvement. And I'm just drawing attention here to a great framework that was actually published recently by some colleagues and others around data governance for health data collected from Black communities in Ontario specifically. And there's already lots of data governance around Indigenous data collection, as I'm sure you know, but this is new for the Black health community, and you can check out this report at blackhealthequity.ca. The third strategy is to partner with patients and communities, and we've talked about that obviously related to data, and I've illustrated that I think in my QI story, and I do think that this is so foundational. It's foundational in quality improvement more broadly, but it is really crucial to addressing equity. And patients and communities, they can help us identify priorities, they can help us understand the problem, co-design solutions, test the solutions, interpret the data, and spread and sustain it. And, I think this was just one of the good news stories during the COVID vaccine kind of campaign. We've seen communities come together and organize for themselves, in particular the Black Physicians Association of Ontario and here the Jamaican Canadian Association. They organized, these Black-led community pop-ups in some of the hardest hit areas in the northwest of Toronto. And it's, thanks to them that we're really seeing some of those vaccine rates close or improve in those areas and catch up to the rest of the city. And you can see some photos of the success of that clinic on the right here, led by one of my colleagues, Anya Norm, and others. So, it's just a testament to how important it is to partner with communities to be able to offer services in a way that is culturally safe, appropriate, and welcoming, acceptable for folks. The fourth strategy is to really consider the resources available to particular populations, and this, obviously some very practical issues like their living situation, finances, education, transportation. And I think, a lot of these seem obvious, but it's amazing how often when we're immersed in kind of the QI journey and designing an intervention, we may lose sight of them. And, one of the things that I've encouraged our students to do when they do QI is to actually, when they're doing a cause and effect diagram, just really lay out social determinants of health as a completely separate arm. And that allows you then to make sure that you're thinking about it as a potential root cause and something that needs to be addressed. Similarly, you can also do a targeted literature review. So often the interventions that are going to support equity or that are targeted towards certain communities that are experiencing worse outcomes are not going to be the same as the interventions that that work broadly. There may be sometimes subtle and sometimes large differences. And so then, again, I think we can look to the COVID vaccine for some examples. I loved this photo that came on Twitter that said, booking vaccine Ontario is going crazy here. And that's how it has felt for so many people. And, I feel like I've lived this experience every day trying to help my patients get an appointment, which has been super frustrating. And then, of course, there's, folks like vaccine hunters that seem to have saved the day and through their communications on social media, alert people to where are their appointments. But of course, what we've set up here is a system that allows people with certain resources to more quickly access vaccines. So if you're English speaking, you're internet savvy, you've got time because you work from home, you're better able to navigate that complex booking system. I've certainly, unfortunately, been at, pop-up clinics where, the pop-up clinic will open it up to more postal codes, and then who comes in? It's the people who are sitting at home looking at their social media feed and see vax hunters tweet out that that this clinic now is offering doses to anybody. So we set up systems that really favor certain types of people. And I think to balance it out, it's been good to see some other kinds of distribution. So there have, of course, been the pop-ups that we've seen, some of the long lines that really illustrating the desire to get vaccinated in some of the racialized neighborhoods. But I think this was a particularly unique event in Peel, Doses After Dark, that occurred, I think, just this past weekend. And so just a recent Toronto Life snapshot of some of the people who attended. But so Toronto Life was there between 10 p.m. and 1 a.m. And who attended during that time? Well, it was people who work, someone who's a sous chef, a truck driver, a technician, an HVAC worker, and a warehouse worker. So people who are working and can't get to a vaccine clinic during the day, this Doses After Dark offered an opportunity. And it just illustrates how when we're designing our systems and our interventions, how we need to really keep in mind what's possible for people. The fifth strategy, is to really try and directly address the social determinants of health from within the health system. And so this one is something that, most of us are not doing, but some of us are starting to do. And I think there's growing research from the United States in particular about the effectiveness of this strategy. What I'm sharing here is the result of a cluster RCT done in pediatric clinics in Boston several years ago, actually, in the We Care study. And they did a fairly simple intervention where they screened for social need in the waiting rooms of these pediatric clinics. And then when the patient and family screened positive, they came into the clinic, the clinician really, I think, went over some resources. So I think there were just literally printed out pages of resources that they could go over with the patients. And the intervention, though, was really remarkably successful. At the 12-month visit, they saw that We Care mothers, were more likely to have enrolled in community resources. They had greater odds of being employed, greater odds of getting childcare, of receiving fuel assistance, and lower odds of being in a homeless shelter. So a simple intervention to screen for social needs and then try to provide resources to address them really had some impact. And I think there's growing evidence now in the U.S. that around some of these trying to link this to health outcomes like A1C control. And there's starting to become some evidence around that as well. But of course, some of those things are very distal and will take time to influence. I think in the COVID context, it's been great to see some COVID assessment centers and other places really start to put this into action. So this is, I think, from Vanessa Redis, a colleague of mine at Women's College, they have a COVID equity committee, and she sort of shared these resources that their CAC has been using. And I think that now we actually have on our CAC as well to ask people, are you some basic questions around needs, and then really refer them to 211 as a great place of support. So by calling 211, they can access a whole bunch of things from groceries to finding safe housing to emergency financial assistance. So a great example during COVID of how I think people recognize the importance of doing this. The sixth and final strategy I'll share is relating to really influencing what I would call the structural determinants of health. And this is something that I've learned more about through colleagues like Andrew Pinto, who I work with. And in this case, I've shared a diagram of Nanki Rai, who's a resident, who was a resident, who's now a family doctor, but who was a resident in our practice several years ago. And, really the structural determinants are those determinants of the determinants. So, I think for a long time we've been focused on the issues of, income and housing and education and those social determinants of health. But what are the determinants that drive those determinants? Often they are, unfortunately, things like our history of colonialism and racism within our medical community, sexism, homophobia. And so I think this tree that Nanki kind of put together really helps to illustrate kind of how that is. So you see at the roots here, those structural determinants going up then to impact. The branches, which are the social determinants, and then those fruits are the impacts, and whether that be life expectancy, mental health, infectious disease, etc. So, I think this is a hard thing for us, I think, as healthcare practitioners to tackle. I think it's been new for me for the last couple of years. Trying to reflect on and address issues of racism within our own clinic. It's not an easy thing. And I think what I would recommend for all of you, if you haven't already started on this journey, I know so many of you have, is to go further to educate yourself, because I think all of us can learn more in these areas, to reflect on how we can be an ally, and that includes reflecting on kind of our own privilege and where we are coming from, and in the privilege that we have that others don't, and then how we can use that privilege to be an ally, and then how we can act in our institution to make it a safer space for colleagues and employees who may be experiencing, for example, racism, but of course also our patients through things like the Indigenous cultural safety training. That is just really something I think that all practitioners in Ontario need to do. It's a very tangible way in which we can educate ourselves on the historical issues, understand how to be an ally, and how we can better create culturally safe spaces for Indigenous partners particularly. And so I think going back to this idea that we're not all in the same boat, and I think I've shared with you a lot of data today that hopefully illustrates that this is not just, it's true during COVID, but it's been true for unfortunately for decades before that. And that some of the keys for us to addressing the issues of us not being in the same boat is to, of course, recognize it, first of all, understand and see that, understand the perspectives of those in the other boat, but then also do a deeper reflection to understand why we are in the boats we're in. And then really work to, maybe we construct a whole new different boat, one that we can all be on together, rowing in the same direction. I like to think of those, giant, almost like Voyager canoes. Can we all be in that, rowing in the same direction as we think of a brighter future world? So thanks so much for having me today to open up your QI symposium, and I look forward to some great discussion now.